Hi, welcome. I'm Dr. Vijender from YourPedia, and today I'm at Biomedical Instrument and Device Hub, a center for innovation design and clinical validation in PGI Chandigarh for the technological demonstration. And with me is Dr. Joseph Matthew. Welcome, sir.
Thank you.
So, Dr. Matthew, I have some queries, some points related to the technology we are going to demonstrate today. And here I go. So, what is the need of this technology and what are its applications?
So, in many hospitals, patients who need mechanical ventilators cannot get it either because there is shortage of ventilators, or there is no ICU, or there is no trained personnel to deliver. Such patients often end up getting hand ventilation with an Ambu bag.
Okay.
That is an unsafe procedure, it's an uncontrolled procedure. So, we have devised a technology to make manual ventilation obsolete and replace it with a much safer and more efficacious electromechanical system.
That's true.
That is this device.
That is this device. Dr. Matthew, is there any existing technology in this domain? And if yes, what are its limitations?
Okay. So we started working on this in 2016, at which time there was nothing available in the market which could replace manual ventilation with a machine.
Okay.
During 2016 to 2020, our device went through multiple development phases, laboratory testing followed by clinical testing.
Okay.
During the COVID pandemic, several engineers, innovators, and even companies tried to make such machines, and some of them had disastrous results, primarily because they were not able to ventilate patients, even though the machines could compress these self-inflating bags. So currently, we think that there is no machine which is available in the market that has gone through robust lab testing, patent process, clinical testing, and proven to be safe and efficacious in that.
Wonderful. So, what are the advantages of this inventor technology over the existing technologies, if they are existing?
So, there is no existing technology.
So
therefore, this fills a gap in the clinical healthcare scenario. At the same time, ventilators are very expensive. This device is able to perform almost the same functions as a ventilator, but at much lower cost. Second, the hand ventilation, which is unsafe, which is sometimes unethical, can be completely replaced, and the machine will perform the functions, which makes it completely unrequired to do hand ventilation.
Wonderful. So, Dr. Matthew, what is the readiness level of technology, which normally we call TRL?
Oh, so this project started with a TRL of 1. We had only an idea in mind, and now it has reached a TRL of 9. In the sense that it has been commercialized. The company has rolled out the first few units. We are still lab testing them to make sure that the patients will be safe when they are used. So I would say between 8 and 9.
Wonderful. Is technology patented? And if yes, what is the current status of the patent?
Yeah, so this is the only device which has been patented, and our patent is in 2018, 1st of June. So we started working on this, like I said, in 2016.
Right.
So some other patents of other companies are now stuck because this particular product is patented.
Wonderful. So, Dr. Joseph, now coming to very important part, that is a clinical validation of this. So, has the technology been clinically validated, and where was it validated?
All right. So, this device has been clinically validated in PGIMER Chandigarh with approval of the Institutional Ethics Committee. We have tested over a period of 1 year 24 patients. These are patients who are critically sick, had no chance of survival, and they were on hand ventilation. And this machine was able to ventilate them successfully. So we have ventilated our oldest patient being 82 years of age. Our youngest patient was just 2 months of age. And the device performed very well. The data has been reviewed. So we are able to ventilate with this machine adults, children, and also infants. We have little difficulty in ventilating below the weight of 7 kilos, but older infants we are able to ventilate.
Wonderful. Now, Dr. Joseph, coming to the result part of the validation, what results were obtained during the clinical trials?
So we collected a lot of data during the clinical trials. We looked at the vital sign parameters of the patient. Every minute these were recorded in an Excel file. We had electronic recording, we had manual recording. We did blood gas levels and arterial blood to look at the ventilation parameters. And all of this we have put together to conclude that in the 24 patients, we had success, 100% success in 21.
Wonderful.
3 infants which were between the ages of 2 months and 6 months, we had little lower success.
Now, coming to the number of such trials conducted, does this technology require more clinical trials, or is it fully ready for the commercialization?
So, based on the clinical trial data, we have commercialized this technology. the company will roll out this. The first 10 units will be donated by the company to PGIMER so that we can do additional testing on a variety of patients. This is only so that we as inventors are completely satisfied that the machine is safe and efficacious.
Wonderful. And when we talk about the market which is available, what market potential do you see for your technology, Dr. Joseph?
So we see a great market potential simply because there is no device at this moment which is in between manual ventilation and a mechanical ventilator. The cheapest mechanical ventilators cost upwards of 2 to 4 lakh rupees and high-end ICU ventilators may go from 10 to 20 lakh rupees. Manual ventilation has no cost except of the device itself, but this device would be priced in between. So it would come to about 20 to 30% of the cost of a cheapest mechanical ventilator and definitely much more safe than a manual.
Okay, wonderful. So Dr. Matthews, now specific target industry or industry sector for your technology commercialization you have in your mind?
Right. So we would like a company which has got some expertise and experience with life-saving medical devices. A company which completely makes in India to fulfill the requirements of Make in India and Atmanirbhar Bharat. And a company which has got a good reach across different segments of the healthcare sector. Right from tertiary care hospitals to small private nursing homes, smaller level hospitals, and even secondary healthcare facilities which are in remote and distant areas.
Wonderful. So Dr. Matthews, I would like to deviate a little bit from the questionnaire I prepared and ask you another question, and that is related to when you are saying that such kind of technology is not available in the market, you are talking about the market in India or globally?
So in India, definitely nothing is available. Global has not even thought about this. Developed countries don't need these devices because they have lesser population and they have enough mechanical ventilators.
Wonderful.
Countries in developing world, for example, Sub-Saharan Africa, South America, Southeast Asia, which are kind of in the healthcare scenario like India, have great need of this kind of devices.
So those are the countries you are targeting as of now?
At the moment, yes.
Okay. Now, Dr. Matthews, would you like to give the live demo of this particular technology to all the viewers over there?
Certainly. Hello, I am Joseph Matthew, Professor of Pediatrics at PGIMER Chandigarh. And today I'd like to demonstrate this innovative device, the Artificial Breathing Capability Device, abbreviated as ABCD in short. Now we had invented this device a few years back because many patients with respiratory failure who need mechanical ventilators in hospitals are unable to receive this ventilation support because of the shortage of ventilators. Mechanical ventilators are expensive devices. They need an ICU setup and trained personnel skilled in providing mechanical ventilation to the patients. In every busy hospital in India and also other developing countries, there is a shortage of these ventilators or the ICU facilities or skilled personnel to operate these ventilators. Therefore, very often patients end up getting ventilated through manual ventilation. In manual ventilation, a tube is placed in the airway of an individual and then an Ambu bag or another self-inflating bag is compressed intermittently either by hospital personnel or the patient's own relatives to provide ventilation support to the patient. Now this is completely an uncontrolled procedure because sometimes untrained family members have to do this ventilation. They might use excessive pressure which can create barotrauma or pressure related changes to the lungs. They might compress either weakly, in which case there is not enough ventilation going to the lungs. They might create excess or deficient volume of air which goes in, and many other problems such as tube disconnection, tube blockage, dyssynchrony with the patient's spontaneous respiratory efforts and the manual ventilation can also occur. For these reasons, even though manual ventilation can be life-saving at times, being an uncontrolled procedure, it is fraught with danger and can also create complications and problems. One of the big problems of this uncontrolled ventilation is pneumothorax, wherein air leaks out of the lungs into the or the pleural space, creating this pneumothorax, or sometimes into the pneumomediastinum, which is very complicated and then requires additional management by itself. So we wondered in early 2016 whether we could devise an equipment which could replace this manual ventilation, provide ventilation at the same levels of care which a patient needs, and have the whole process controlled or automated through an electromechanical system. So we worked on this for about 2 to 3 years and have succeeded in creating this artificial breathing capability device, or ABCD for short. And this is the first prototype of our device. What you can see is it's a little structure which has got an Ambu bag or another self-inflating bag placed inside. There is a ventilator tubing which goes from this Ambu device, gets into the endotracheal tube of the patient, and here the patient is being simulated by this electromechanical simulator device which is present at the Biomedical Instruments and Devices Hub. Now this device or this machine simulates a real human being, and when we ventilate this particular patient, we can see the changes in his heart rate, oxygen saturation, breathing parameters on the computer screens, which I will demonstrate in a short while from now. Now this device we worked on for about a year. We made multiple designed innovations. We redesigned, redeveloped this, and ultimately put it for laboratory testing in an intensive manner. So we used a 60-day non-stop continuous laboratory testing profile to make sure that the device would not undergo mechanical failures, electronic failures, and electrical failures. The device is very versatile. Having gone through this testing for 60 days non-stop, besides testing with various user combinations for a period of 1 year, we were convinced that this device can be taken up for clinical trials. Currently, the device is capable of performing ventilation almost like a high-end mechanical ventilator. So a user can set peak inspiratory pressure in this particular device, ranging from as low as 10 centimeters of water to as much as 60 centimeters of water. He can set up in this a peak end expiratory pressure using an automated PEEP valve, which can generate a pressure from 5 to up to 20 centimeters of water. This device has got a flow sensor which will enable us to calculate and measure in real time the flow of air or air oxygen mixture, and through a calculation of the flow also able to calculate the volume of air delivered to the patient. We are also able to set inspiratory to expiratory time ratio in any fraction ranging from 1:1 to 1:4, just like a mechanical ventilator. This device has a lot of safety features. We've got built-in alarms in this. For any pressure which goes outside the controlled range, 10 or plus or minus 10%, there will be a beep. If there is a volume which is excessive, there will be a beep. If the flows go out of range, there will be a beep. And different kinds of alarms for tube blockage, tube disconnection, endotracheal tube blockage, and also for what is called a cough alert. The cough alert is a very important modification in this device. If a patient tends to cough while the ventilator is trying to deliver a breath, the two opposing pressures can cancel each other, sometimes can even create volume and pressure effects on the lungs of a patient. So this device has a nice mechanism wherein if the patient tends to cough while the ventilator is trying to deliver ventilation to him, then the device detects it, cuts off automatically for a preset variation in time, duration of time, and then resumes with the same settings. Let me now demonstrate how this device actually works. It is really simple to use. When we switch on, the device performs some automated self-checks so that it calibrates itself and then gets ready to use. The first parameter which a user can enter is the PIP, or peak inspiratory pressure, just like a ventilator. So I'm now going to set a pressure of 24. So I enter the number 24 and I say yes. Immediately the ventilator asks me to set a desired rate. This device can ventilate at a rate as low as 10 per minute to as much as 60 per minute. Most other devices of this kind are not able to go beyond 30 per minute. But this device has got a very fast motor in which we are able to ventilate up to 60 per minute, which is required sometimes in pediatric age group and also newborn infants. So let us set a respiratory rate or ventilation rate of 30 per minute. This means each cycle would be for 2 seconds duration. The next parameter it would ask us to enter is the IE ratio, or the ratio of inspiratory time to expiratory time. So I'm choosing an inspiratory time of say 1, and we will select it to a ratio of 2.5 just to show you the capabilities of this device. And immediately the ventilator will show us the parameters that we have set, and it also calculates the inspiratory time. Thereafter, it immediately starts ventilating and providing the parameters, and in real time what we can see here is the actual peak inspiratory pressure. So you will see we set 24. It is delivering 23.8 to 23.6 or 23.5. With each breath, the actual pressure delivered is detected by a pressure sensor located in this device, and these numbers, which are varying with each breath, are actually demonstrating the delivered pressure at this time. You can see that the device had no lag time to deliver the set pressure. Many other automated Ambu devices, which have subsequently been developed during the COVID pandemic, attempt to replicate this machine, but they are not successful because there is a lag time of 30 to 60 seconds before the ventilator actually delivers. So the BPM stands for breaths per minute. It is fixed at 30, so it's delivering 30. The inspiratory to expiratory time ratio was set at 1:2.5, which in terms of decimals is 0.40. And you can see that this machine is varying between 0.43 to 0.44. And the inspiratory time is exactly as we set. The PEEP here we have not set, because the PEEP can be set through an automated valve through any number that we desire between 5 and 20 centimeters of water. Why this device is really useful is because after the initial laboratory testing, we tested this for a year in different ambient conditions of different air speeds, different climatic conditions ranging from very hot to very cold. We set up high-speed fans to simulate air currents. We set up other electronic devices which could provide electromagnetic and electronic interference to this device. And the device passed through all these tests with flying colors. We then tested this on a virtual instrument laboratory by which we could test for reliability, robustness, and also precision. We are very keen that these devices should not have any drift. So when we set pressure and we use it over a long period of time, the pressure should not change, the volume should not change, there should be no drift in the recorded parameters. And we took a year of testing in the lab just to make sure that all of this worked. And after this was tested in the lab for about a year, we then set it up for non-stop testing for 60 days without stopping the machine at all. And during this, we tested 396 combinations of user settings. A user setting basically means a combination of peak inspiratory pressure, breath rate, and inspiratory to expiratory time ratio. This device performed very well with an adult-sized Ambu bag, which is about 1.5 liters capacity, followed by a pediatric-sized Ambu bag, which is about 500 milliliters of capacity. So 2 cycles of 60-day non-stop testing, and after that, the results were submitted to a prestigious international journal, published, and therefore is now deemed to be acceptable. Not satisfied with that, we also took this device with appropriate ethical approval from PGIMER into real-world clinical testing of real human beings. And we've been able to test this device on 24 patients. These are patients who had terminally ill condition, which means that their chance of survival was deemed to be next to 0. They were put on this manual ventilation in different emergency departments of PGIMER Chandigarh simply because there was no ventilator available and the condition of the patient was deemed to be fatal. 24 of these patients were ventilated and the ventilator performed excellent service. The ventilation parameters were achieved in the real human patients. And interestingly, some of these patients who were deemed to be unfit to survive actually recovered, came out of the ventilator and were discharged to go home. This data has been also declared and published to the world. We have got this data reviewed by committees within PGIMER and also the DST, after which we were confident that this machine can be used both in children as well as in adults. We did try to ventilate some young infants below a weight of 5 to 7 kgs. We encountered some difficulties therein, but we were able to remodify the device and make some variations in the way the pressure is delivered. So currently, this machine has got the capability to be used even in infants below the age of 1 year. So it's a universal device which can ventilate adults, children, and also infants with diverse lung conditions. Now, after this process was completed, we commercialized this device. So the commercial license has been provided to 2 different companies. One is based in Baddi, the other is based in Ambala, and they have rolled out the first few prototypes of this particular device, which I will show you in a moment. Now, a word about other devices of this kind. We started working on this device as far back as in 2016. During 2017, we had the initial prototypes ready. During 2018, we did the initial lab tests, based on which we went and did revision of the design, revision of the development, and by 2018, we had the device ready. Almost the entire 2019 was spent in lab testing and 2 cycles of 60-day testing as I described. And then in 2020, we were ready for clinical trials. That is the time when the COVID pandemic hit. And because of the COVID pandemic, there was delay in initiating the clinical trials. Now, during the COVID pandemic, many other innovators in the country, especially based in engineering institutions, also some organizations and companies, and also some medical institutions, tried to replicate the process of automating the Ambu device. None of them have succeeded, even though several claims have been made, primarily because they looked at automating the compression of the Ambu device without looking at controlling the ventilation. This device has succeeded where others failed, primarily because the development team comprised medical professionals based at PGIMER, led by myself, engineers from IIT-Ropar, led by Professor Naveen Kumar, and also at the University Institute of Engineering and Technology, led by Professor Manu Sharma in the Mechanical Engineering Department and Dr. Sukesha in the Electronics Engineering Department. We were very fortunate that our project engineer, Engineer Ankush Gauri, who was recruited initially as a senior research fellow for this particular project, was able to understand our vision and our requirements and translate what we needed in terms of clinical specifications into the technical specifications, and he is the engineer or the architect who was responsible for the development of this device and the performance of this device as per the clinical requirements. Therefore, this is the only device in our country which has been designed by a medical team, robustly tested in the laboratory over a period of 1 year, followed by 2 cycles of 60 days non-stop testing. The only device which has been patented. The patent for this device was awarded with the date starting on 1st June 2018, way before the other devices in the market tried to look at this particular problem. This is the only device which has been clinically tested in an emergency care setting under an ethics approval of the PGIMER, and then subsequently has been commercialized. The commercial company provided initially 5 to 10 units of this device, but not fit to release directly into the market until we have lab tested and verified that they are performing in accordance with the clinical specifications required. Now, those lab tests are underway right now, and we are hopeful that in the next 30 to 60 days, these units will then be available commercially in the market. So this is the device, and the DST has appreciated this device. I'm also pleased to note that this device was demonstrated at a prestigious international conference in the United States at the annual conference of the American Society of Anesthesiologists. This device was accorded the 2nd prize for the best innovation which has taken place at the global level because this meets the challenge of lack of mechanical ventilators in developing country settings. I must mention here that some of the copycat devices which came out during the COVID pandemic have been feted in the lay press. A lot of publications have been made in the newspapers and journal art and also into the YouTube websites. But if you look at where these devices are today, you'll observe that most of these devices are not available to be sold in the market. And the reason is that they don't work. A couple of devices are being sold, but they have limited capabilities in the sense that they have limited application in terms of pressure range, respiratory rate range, and also the volume which can be delivered and the inspiratory to expiratory time ratio. So we believe that this device has got great potential in hospitals which are tertiary care centers but don't have enough ventilators, in smaller hospitals, nursing homes and care clinics where ventilation is an option but they don't have an ICU or skilled personnel, and we also expect that in due course of time, for patients who require chronic ventilatory support even at home, there might be a way to use these devices at home. This in a nutshell is what this device is all about, and we will now move on to the next phase of testing this on a clinical simulator, and I will show you the demonstration in a short while. So this is an electronic simulator device for clinical simulation experiments. You can see on the screen right now that this patient is apneic. He is in respiratory arrest or failure. He is barely maintaining his vital signs but his oxygen saturation is dropping and it is down to the 2 digits now. There is no airflow, so the EtCO2 is turning out to be 0. Now it is in situations like this that patients need artificial respiratory support, which our device, the ABCD, can give. Say here I'm giving a demonstration of operating this device to support a patient's respiration. So this device allows us to enter an inspiratory pressure. I'm entering here an inspiratory pressure of 18, a desired rate of approximately 20, and an IE ratio of 1:2.0, which is what we would use in patients like this. The device immediately displays the parameters which have been set, calculates the inspiratory time, and at once starts delivering. So the beauty of this device is that it is able to deliver the pressures which have been set within the first couple of breaths. So you might recall we set a pressure of 18 and this machine is delivering a pressure of between 16 and 22. As this ventilation machine starts delivering air into the patient's lungs, you can see that his saturation is coming up very rapidly. There is an end tidal CO2 which is now coming back to the normal range, and within a period of 30 to 60 seconds, effective ventilation is taking place, whereby this patient simulator is now becoming normal. So those disturbing alarms have stopped because the saturation has touched the limit of 92, which is what the alarm was set at. And now you can see that the heart rate has stabilized, the saturations have become normal. What we can also see through this little device here is the volume of air which is going in. So you can see that each lung is showing up a volume from 1150. One bar represents the right lung, the other represents the left lung, and with each inspiratory breath which is going in, the volume goes up to almost 1400, which is like 250 milliliters of air going to the right lung, 250 ml going to the left lung. So that's about 500 mLs of volume in a tidal framework. Now this is what a patient would look like in an adult who's having a respiratory failure but with relatively normal lungs, in the sense that he has not very high pressure requirements. We could also reset this particular device to go for higher ventilation parameters, and I will show you that also in a moment. So we'll switch off this device briefly for a minute, and as we switch off the device, you'll find that there is no ventilation going in. So the end tidal CO2 starts to drop down. The saturations will take a little while to drop down as well. Meanwhile, we will now simulate a patient who's got damaged lungs and requires far higher pressure. So I switch on the machine again. The machine does its own self-check and then allows me to enter the desired pressure. This time I'm going to enter a pressure of say 36, which is a reasonably high pressure. We set that. The desired rate is going to be set at 24, which is a higher rate, and I'm setting an inspiratory to expiratory time ratio of 1:2.5. So the machine performs its own self-checks. It shows us on the screen what we set it as and immediately starts responding. You might recollect that we set up a peak pressure of 36 and you find that the machine immediately is delivering 35.7, which is exactly where we had set it. Anytime the pressure deviates to either less than 90% of what was set or more than 110%, there will be alarms and things. And you can see that the patient, in this case the simulator, responded beautifully. The alarms have stopped. Within a few seconds, the SpO2s have normalized. The end tidal CO2s are going up. And if you look at this, what you find here is that the volume now being delivered is going up to 1550 approximately. So each lung is getting about 350 to 400 mils. So the tidal volume being delivered here is about 700 ml. Theoretically, we can use this device to go to a tidal volume of up to 1.5 liters of capacity. So this is how this device is working on this particular simulator. The device also has several other novel features which have been built in for safety. If there are endotracheal secretions which are jamming this endotracheal tube which is inside the patient and a tube blockage occurs, we will now simulate a tube block by compressing this tube over here, so to prevent the airflow. So this is a real world situation in which we often find this. You can see that there is a decrease in the flow, so the patient monitor has picked it up, and you find that the ventilator is delivering a higher pressure than expected, and an alert sets in until we relieve this tube block. this will be continuing like that. We also have in this mechanisms in case the tubing of the ventilator gets disconnected like this. You see that there is not enough pressure which is generated. Immediately an alarm goes on the screen to check the ventilator tubing. So this is a safety mechanism which has been built in over here. So in the same way we have an alarm if this self-inflating bag gets displaced or it is not in the right position, there is an alarm on the screen which comes up. And the best feature of course is the cough alert. We know that when the ventilator is trying to push in air into the patient's lungs, if the patient is coughing out, the two opposing pressures can work against each other. There is no way for the pressure to be released. It blows back to the lung and can damage the lungs, creating pneumothorax. So this machine is able to actually simulate or recognize that cough and then detect it, pause for 3 to 5 seconds as set by the user, and then resume the settings wherever it was left. So this in a nutshell is how this works in a real world scenario. And besides the simulator which is being used for demonstration today, the machine has been tested on 24 patients as I described before, live patients who are in the various emergencies of PGIMER Chandigarh, and some of these patients who were deemed to be unfit to survive, had no chance of survival, actually recovered, improved, and some have been discharged and sent back home as well. So this is a clinical simulator. Right now the simulator has been set to show a patient in apneic phase. So the patient is not breathing. So if you looked at the screen, the end tidal CO2 is 0 because there is no airflow. The patient saturation is dropping. It started off from 95 but it has come down to the 70s. It will continue to drop further. And if you look at this particular laptop, we can see that there is no volume being generated in the lungs, which is based on these two bars over here. So we will now set this patient to receive ventilation with this artificial breathing capability device or ABCD. It's very simple to use. I switch this machine on and the machine displays its name, and thereafter it allows the user to enter a peak inspiratory pressure. So I'm setting a peak inspiratory pressure of 20, then a desired respiratory rate which can range anywhere from 10 to 60. Let's set it up at 18, which is usual for an adult, and then an inspiratory to expiratory time ratio which I'm setting at 1:2.5. So the machine immediately displays on the screen what has been set for the user to make a second check to know that it is exactly what he preferred. Now the beauty of this machine is within the first couple of breaths itself, it delivers the desired pressure. So we set a pressure of 18 and it is delivering with each breath about 18.8. Anytime it deviates to either plus or minus 10% of what was set, an alarm will go off over here. You can see immediately that there is now air flowing into the patient's lungs. So this patient monitor is showing us an EtCO2. The saturation has risen up from the 70s right up to 90s, and when ventilation is successful, it will reach the normal range of 95 to 100. In addition to this, we can also see that this little device here is showing us the actual volumes which are going into the two lungs. So from the baseline of about 1150, this is reaching to about 1400 mils in each lung. That's about 250 ml of air being delivered to the right lung and an equal amount to the left lung. So that's about 500 milliliters of volume being delivered in a typical tidal fashion. But this was a simulation to show that the patient now seems to be stable. He has achieved his vital parameters, the saturation is back to normal, the end tidal CO2s are in the acceptable range, and the volumes being delivered are also acceptable. Besides these kind of efficacy, we also have certain novel features in this device in terms of patient safety. One of these patient safety features is the cough alert. If the patient coughs when the machine is trying to deliver air into the lungs, the machine senses that, it will auto cut off for a preset period of time and then auto resume with whatever settings were instilled by the user. Now here I'm simulating a situation in which there is a disconnection in the ventilator tubing. So when the ventilator tubing gets disconnected, the pressure sensor here picks it up and immediately shows up, check the ventilator tubing. When patients are being ventilated by hand, this kind of safety is not available, and sometimes the patient gets compression of the Ambu when the circuit itself is incomplete. This also has other additional features. You will observe on the screen that as soon as the ventilator tubing was disconnected, without any lag, the preset pressure has been recorded and it is actually delivering. The screen on the machine actually displays what is happening with each breath. So these are not the set parameters, these are the parameters which are being delivered with each breath and read on the display screen over here. We also have a tube block alarm. I'm simulating a tube block by compressing this particular tube. So when that happens, again you'll observe that airflow diminishes. So you'll see that there is an alarm and the machine says an audio and a visible alarm that there is a tube block. So I'm releasing this as the patient's condition seems to have deteriorated. So I release the block and immediately you find that things are back to normal again. So some of these safety features have been built in just to ensure that both the user and the patient has a relatively efficacious and safe ventilation using this artificial breathing capability device. So it has the capabilities of a conventional mechanical ventilator, but at a fraction of the cost, and for settings in developing countries where ICU ventilators are not available, or an ICU itself is not there, or skilled personnel to operate these ventilators are not available, this can be a potentially life-saving device and benefit the patient and the healthcare system.